Okay. Brilliant. I think we're recording. I think this is the point at which I take over. So thanks, Steph, for operating the slides for me, and thanks everyone for your time today to come and listen. My name is Laura. I am a public health doctor and I work at the Integrated Care Board in Derby and Derbyshire, doing what is officially called population health management, but can probably be better described as helping the Integrated Care Board do some of its sort of more public health functions as opposed to the frontline medical stuff. So my background is that I'm a medical doctor who used to do obstetrics and gynecology, and then I transferred to do public health. So in the past have worked quite a lot on things like vaccination programs and infectious disease control and management. So I'm kind of bringing some of that today. But what I should say is, although I'm the one talking through the slides, Mandy and Lewis and Steph and their team are the ones who do all of the work, the hard work, really getting this up and running and out to the people of Derbyshire. So thanks to them. And also, please, guys, if I say something that you disagree with or want to add to, please just jump in. Could I have the next slide, Steph? Fab. So the reason that we are here talking to you today about vaccinations and various other things is the fact that, unfortunately, well, I guess depending on your viewpoint, I'm a summer person, but it's the season of falling leaves and Halloween and Christmas and pumpkin spice lattes, and unfortunately also respiratory illness. Lots of bugs and unpleasant illnesses get more common in the winter months for lots of reasons. There's more of it just about the colder weather, people spending more time inside, more likely to close the windows, etc., etc. So what I'm showing you here is a graph from last winter. So it shows October 2024 through to October 2025. And it's the number of people coming to emergency departments in the UK, in England, sorry, with flu-like symptoms. So that kind of cough, cold, fever, achy joints, feeling really unwell. And you can see there's a really obvious peak in attendances between December, January, and then it goes down gradually over the next couple of months. And that's a pattern we see every year with flu. Can I see the next slide, Steph? And so this is a similar bit of data. So this is showing, instead of people going into emergency departments, so we can people who are sort of staying at home but still ill, these are people calling NHS 111 for advice. And the category there is acute respiratory infection. So this is anybody who's suffering with coughs, colds, shortness of breath, feeling unwell. And you can see there the same thing happens. You get that real, although there's quite a lot of day-to-day variation, you get a real peak in people phoning December, January. And we know that this becomes a real problem for everybody, which is why we focus on some specific vaccination programs and other preventative things around this time of year. Next slide, please, Steph. So, as you will all know, lots of illnesses get more common in the autumn and winter months. So flu and other similar viruses. So there's a whole family of viruses called para-influenzas that aren't flu exactly, but have similar effects. COVID-19, of course, although we see a level of that kind of at the moment throughout the year, because it's a respiratory virus, we do see peaks in the winter. Norovirus, unfortunately, deeply unpleasant winter vomiting virus, tends to start making its appearance about now. And lots of other kind of chest infections, so they can be bacterial or viral pneumonia cases. We also see those increase. And the other one I'm going to talk about a little bit more in a minute is RSV, which is perhaps less familiar to people, but actually just as important. And that's another viral chest type infection that gets much more common around the winter months. Obviously, everybody suffers from these, and I'm sure everybody on the call will know what it's like to get a winter cold. However, there are people who are more at risk of catching these illnesses, becoming severely unwell with these illnesses and needing hospital treatment. And those include, so people who are younger or older, so people over 65, in particular people over 75, or babies and children at the other end of their life. People with long-term health conditions, and there's a whole range of those, people who suffer from disabilities, people who are pregnant, and often people who are on lower incomes, so they're having difficulties with food or heating costs, and that also puts them at risk of these winter illnesses. Next slide, please, Steph. So because of these increases in circulating illness and disease, and because we know that some people are more at risk than others, the NHS offers a few vaccination programs that focus specifically on those seasonal infections. And we're talking here about COVID, about flu, about RSV, and so they come around at this time of year. And I apologize that people in the call probably know this, but I thought I'd go through it anyway. So the way that vaccines work, they're not a medicine in the sense of paracetamol or aspirin being a medicine. What they are is either a piece of a germ, a virus or a bacteria, depending on what you're talking about, or it's a whole version of that virus, but modified to be harmless, if you like. It doesn't cause the disease, and that's injected into the body. And then what that does is teaches the body to recognize that this is an invader and allows it to manufacture antibodies, the things that fight that germ. So that means that if you've had a vaccine, if you go on to encounter that infection while you're out and about in the wild, as it were, your immune system doesn't need that period of time to learn what it is and fight it. It immediately is able to say, this is an invader and we remember this one and we can make antibodies to fight it. So what that means is that there are some vaccines that will basically prevent you from becoming ill at all, and some vaccines like that. So measles, for example, if you've had a full course of a measles vaccine, it's very unlikely that you will ever get measles. However, some bugs, because they've changed so much and because they come around every year, it's more difficult for a vaccine to completely stop you getting the infection. But what they do is make it either less likely that you will catch that vaccine, or if you do get it, it means you'll be poorly for a shorter period and the illness will be less serious. So the idea is that they catch it more quickly. They teach your immune system to recognize what it is and to fight it more efficiently and more quickly. And they've got lots of positive effects. So primarily we talk about vaccines because they protect you. So as I've said, you're less likely to become seriously unwell if you've had a vaccine. You're much less likely to need to go to hospital or need, severe treatment like having a breathing tube down to help you breathe. And it will also shorten the time you're unwell. And because of these things, because you tend to be less poorly and for a shorter time, you're also therefore much less likely to pass the infection on to other people. And that's really important, particularly if you live or work with people who are vulnerable, either very young kids or older people or people who have long-term illnesses. It also protects everyone as a group. So in general, the more people in any given community who are vaccinated, the harder it is for infections to spread, because infections need people to live in and to kind of move around. And so this concept, and you might have heard of it, called herd immunity, and that's the phenomenon whereby if we have lots of people in a population who are vaccinated, the bugs just can't grow and spread in the same way. So it protects everybody. And this is particularly important because there are some people who, for various reasons, aren't able to have vaccines. They're too poorly, their immune systems are too poor, whatever, but they really need that protection from the circulating illnesses. So it's got sort of three levels of protection of vaccine. It protects you, it protects the people around you, and it also protects the whole community. Next slide, please, Steph. So because we now have lots of different vaccination programs against lots of different things, which is great, but it means that knowing what you're eligible for and when can be really complicated. And I know that this year there's been a bit of trouble with people and the COVID vaccine, and some people have thought they were eligible when they weren't, and various other things. So this is a really great infographic that our comms team have produced about who is eligible for what. But basically, flu vaccine is probably the most straightforward because that hasn't changed a great deal in recent times. So if you're a school-aged child, if you're a child who's 2 or 3, or if you're a child of any age but in a clinical risk group, if you're pregnant, if you're 65 or over, or if you're 18 to 65 but in one of those risk groups, including people who work with vulnerable people, you are all eligible for a flu vaccine. Please go along and get it. And we'll talk in a minute about where you can go. COVID vaccines this time around is a little bit more restrictive on the basis that the committee who are responsible for making these decisions have spent a lot of time looking at the circulating data, like virus data and the evidence. And actually, because the level of immunity to COVID is currently quite high within the population, because we vaccinated everyone a lot during the pandemic, The benefit of the vaccination, they've decided this time, is mainly only for people who are in one of those specific age groups. So you're aged over 75, you live in a care home for older adults, or you have a particularly weakened immune system. And there are a list of specific things that will put you in that category on the NHS website, and I can go into those later if anyone needs to know. But it's also, it's a little bit open to interpretation. So do have a conversation with your healthcare worker, your GP, a pharmacist about that if you're not sure. RSV, again, we're going to talk about in a minute. That's a newish one, but you're eligible for that again if you're age 75 and over up to your 80th birthday, if you were pregnant towards the end of your pregnancy. And that, although it's particularly beneficial in winter, you can get at any point through the year. So we'll share these materials as well afterwards. Next slide, thanks, Steph. And I won't go through this because there's loads of information on there, but these are guides as to how you go about getting these particular vaccines, because there's lots of different places that you can go, pharmacies, GP surgeries, and different options will work for everyone. So again, we will circulate these afterwards. Next slide, thanks, Steph. And then I wanted to just highlight RSV vaccinations because they're quite new and people are less familiar with them than they are with flu or COVID. So RSV stands for respiratory syncytial virus, but don't worry if you don't think you'll remember or know how to say that, because we basically never use it. We almost always call it RSV. And although you might not have heard the name before, you probably have come across it in some form or other. It's the main cause of something called bronchiolitis, which is a special sort of chest infection that babies and young children tend to get in the winter. It can be a really serious cause of admission for those babies, particularly babies who are particularly poorly with other things or who have been born prematurely. We never used to do a full-on vaccination program for this. We used to just do selective immunisation of babies and children we knew were at risk. However, the evidence has showed us in recent years that we actually realise now this is an important cause of serious chest infections in older adults as well. Previously, that wasn't recognised so much. And so because of that, the NHS has now launched a routine vaccination program to try and decrease the amount and the severity of RSV infections. And it's in these particular groups. So older aged adults, some infants and young children who are at high risk, like we did before, so that like very preterm babies, and also importantly, pregnant people who are over 28 weeks of pregnancy. And the idea there is less about protecting the pregnant woman, although of course, as often when you are towards the end of pregnancy, you do get more at risk of respiratory infection, so chest infection. But it's mainly about the fact that the pregnant mum will then generate antibodies, which will go across the placenta, and it will help protect the newborn in those first kind of weeks and months of life, because they have quite immature immune systems. And so some vaccines don't work particularly well, RSV being one of those. So this is our best way of protecting newborns, particularly newborns who are born kind of July, August, September, because then they're going to be smallest through that risk period of the winter. It's really important that you get vaccinated. Next slide, please, Steph. So I am about to leave you with some of the other team, but I just wanted to kind of round off with some general messages about keeping well in winter, and probably the biggest and most effective thing that you can do to try and avoid getting seriously unwell in winter is to take up any vaccines that you are eligible for. Please do. They're available on the NHS. There's lots of places you can get them. Yes, that sometimes you do feel a bit poorly for a day or so afterwards, and that isn't ideal, but what they save you from is that potential really serious illness. So do that. Coughs and colds are obviously everywhere, and so it's really important to kind of remember to wash your hands quite regularly, particularly if you're on public transport and you're doing things like touching poles on buses or door handles, because the viruses can sit on there, and then if you touch your face you can infect yourself. A lot of these coughs and colds are really infectious, so wash your hands. Stuff like if you come in from outside, just go and wash your hands. Before you're preparing food, wash your hands, and try and avoid touching your face too much, although we all do that as a habit, I know. If you are poorly, try and obviously limit your close contact with others, particularly if they're vulnerable. Cover your mouth when coughing or sneezing with a tissue, throw your tissue away, wash your hands. And obviously, if you are really poorly, if you can try and stay off work, and I know that that can be really difficult, but it's really helpful to try and not infect people and stay at home if you can. Look after yourself. So simple methods such as just resting, drink plenty. I put drink plenty. I generally do mean like water and tea. I don't necessarily mean whiskey, but whatever works. And simple over-the-counter remedies. So don't forget pharmacists, community pharmacists as a really good source of help and advice and support over the winter. And then finally, staying warm is really important. So although it's a little bit of an old wives' tale that if you go outside and get cold, you will catch a cold, being chronically cold in your house does increase your risk of catching infections. Can I have the next slide, please, Steph? So actually, chronically being cold at home, so not being able to heat your house to a comfortable temperature, increases the risk of lots of health problems, so things like strokes and heart attacks. If you're older, it makes trips, slips and falls more likely because you're kind of more rugged up and you're a bit stiff. It can worsen chest conditions such as asthma or chronic obstructive pulmonary disease, chronic emphysema. It's also bad, for mental health and well-being, having to manage in a cold and damp house. But we also know that it's really difficult given the cost of fuel and all of the other costs that to pay those heating bills and keep your house nice and warm. So there is help and advice available. And I've put a link there to the National Energy Action website, and they're a national charity who have loads of really good advice about how to try and keep your house warm, what to do if you're struggling with energy costs, etc. Because that feels like quite a simple thing, but it is really important for trying to keep you and your family well during winter. And I think that comes to the end of my bit of this presentation. Can I just check, Steph, what's on the next slide? Yeah. So I'm going to hand over now to Carrie and her team to talk a little bit about what they've been doing in terms of engaging with people and how communications are helping with our vaccine programs.
Thank you, Laura. So for those on the call that don't know me, my name is Carrie Carnell and I'm a Digital Communications and Engagement Officer at the Integrated Care Board. And part of my role is to work with the public, but I largely lead on communication, so how people actually hear about what's happening in Derby and Derbyshire. And this year I am leading on a winter vaccination campaign. And I just wanted to kind of go over how communications and engagement has an impact with vaccination programs and sort of what we do to make sure that people can access the right information, knowing there's a lot of misinformation out there around vaccines, but also understanding that I think generally figuring out what vaccine you need is quite complicated. So we're kind of working on a large scale across Derbyshire County and Derby City this year to identify low uptake areas within our areas. We're working with local communities and CVS organisations that help us engage with our population. So as part of this work, we are training vaccine champions within communities. We are helping community organisations run local events by trusted community leads. We're gathering insight and feedback, and we're developing vaccination improvement working groups to create action plans from local insight and data. So for us, our ultimate aim is to make sure that vaccine information works for our communities across Derby and Derbyshire, and it isn't just sort of telling you you need to get a vaccine, you need to get a vaccine. It's understanding the behaviour change around it and why people might not want to get a vaccine, and also what is stopping people from taking up a vaccine or being unsure about how vaccinations work. So by connecting with local organisations and doing a lot of community-led engagement with our local trusted leaders, the outcomes help us to implement long-term change, as well as listening to the voices that know best. I think sometimes it's really easy in the NHS to kind of front it as, oh, with the NHS, you must trust what we're saying. But actually, we can't get that information right if we don't hear from local people and what local people want to hear. So can I have the next slide, please? So I just wanted to go over sort of our communications approach. So alongside the community-led engagement that we're doing, we're also running an actual communications campaign. So communications helps us to get the message out far and wide, and it helps to drive uptake and encourage positive behaviour change. And you might think, well, how do you do that with just a poster? Well, actually, it's a little bit more complex than that. So what we do in order to get information to the right people at the right time is we co-design campaigns with our local communities. We ask for lots of feedback and we ask for lots of voices to sort of help us build what the messaging should look like. We look at local data and insights. So we look at sort of our uptake across the region, seeing where there's some trouble areas and seeing how we can make a positive difference there. We listen to trusted voices and public experience wherever possible. So if you're sat on the call and you're a member of the public and you're thinking, well, how do I get involved with that? There's lots of different opportunities, and I always encourage people to kind of approach us as well through our communications team. We want to hear your experiences and we want to take all of this information on board because it helps us paint a picture of what some of those issues might be. We work with local practices to ensure that they have communication resources and materials. And this is sort of like posters, leaflets and guides. Some of them you will have seen through this slide deck already. And it's basically about creating simplicity with our messages. I know from looking at what is out there, it's really hard to know, how do I even access a vaccine? What vaccine do I need? What am I eligible for? So our role is to make that simple and make sure that people understand what the call to action is. So you'll see through the campaign resources that we'll share after the meeting, the campaign this year focuses around signposting you directly to the NHS website, where you can actually find out just by searching on there where your local pharmacy is, where you can get your vaccine and what you're actually eligible for. So it's kind of that call to action to be proactive about it and keep yourself and your community well. So our campaign so far, we are targeting 3 of the lowest uptake areas, and in the 3 lowest uptake areas across Derby and Derbyshire, we've kind of co-designed a suite of resources that community leads can use, community organisations can use, and then they go out through what is called neighbourhood and place leads. So in neighbourhoods and place alliances, we have a range of different representation there. So we have local authority there, we have the NHS there, we've got people that work on the ground in those communities that get these suite of resources and they can help disseminate them for us. And then we can help evaluate the impact and see if it's actually making a difference. By doing that means that we can also provide quite reactive materials. So if we see something that's not quite right, or actually a certain community would like translated materials rather than materials in just English, we're able to provide that by working in those community areas. We also do really highly targeted social media. So also there's a digital campaign. We know that targets quite a lot of people within our demographics, but we also know on the back of that, there are people in our communities that do experience digital exclusion. So we're very conscious of that. So we do things like targeted letter drops, we put messages on the back of pharmacy bags, and we look at a range of different options. One thing that we're looking at this year is creating materials in British Sign Language, because Derby is the second biggest population outside of London for people that are deaf. So we just want to make sure that they are all round inclusive and accessible to people. I've just seen in the chat there, I know we're not at the Q&A stage yet, but the 3 lowest uptake areas that we are focusing on this year, we're focusing on Glossop, Bolsover, and what's called the North Hardwick area. So we're thinking sort of like North Chesterfield area. Those areas seem to have the lowest uptake, and I'm working very specifically in those areas with local organisations. So for example, you might have seen, if you're in Bolsover, for example, you will have already seen our resources through the Bolsover community newsletter that's gone out, and I'm working with practices in those areas to make sure that they have everything they need to inform their patients when they're coming in. Next slide, please. So I just wanted to go over some additional winter messaging as well. We also run a campaign called Think Which Service. So we run this campaign every winter, and it's basically to help encourage people to use the right service and also think before they access a service. Is it appropriate? Am I going to be waiting for ages? Or, you know, all of the usual things as we're heading into winter. So ultimately, we want you to look after yourself. Vaccines can obviously help you and others from becoming seriously unwell this winter. So it's important to make sure that you go and access your vaccine if you're eligible for it. But alongside that, it's obviously really important to make sure that your medicine cabinet is well stocked. So especially for the little ones, making sure you've got, if you've got little ones like I have, making sure you've got a constant supply of Calpol in the cupboard, paracetamol, ibuprofen, those sorts of things. That obviously is your self-care element. So you're taking proactive steps to make sure that you're looking after yourself. We've kind of broken it down so we can tell you what each service does, and those are accessible. These Think Which Service materials are disseminated to local practice, and we also have a big digital presence on this so people can help navigate to the right service. We also work with the local hospitals who run this campaign as well. So NHS 111 can help you navigate if you've got an urgent medical condition. They can signpost you to the right place at the right time. There's often less queuing, less navigating around complex systems. NHS 111 also have an online function which is really easy to use, and it's quick and simple to sort of report your issue there and get a call back on the phone. Local pharmacy offers appointments and some treatment, including prescribing medications for certain conditions. And they open evenings and weekends, so they're accessible outside of normal GP hours as well. So urgent treatment centres as well, they're scattered around Derby and Derbyshire. They can help with minor injuries such as cuts, sprains, without any of the lengthy A&E waits. They open 7 days a week, so they're open at the weekend as well, and they often open 8 a.m. to 8 p.m. And I know most of our sites across Derby and Derbyshire also have the added bonus of having free parking, which is wonderful. And obviously it's really important to say that 999 and A&E should only be used for serious life-threatening illness. It's easy to want to go there if you've not got an answer straight away or you're struggling to get into your GP. But we know from looking at the data that, you know, A&E waits are bad at the best of times, but especially heading into winter. They should only be used for the people that absolutely need urgent medical help. Can I have the next slide, please? And finally, I just wanted to kind of touch on local pharmacies. I think sometimes it's not very clear what they do other than collecting your prescription, but pharmacies offer so much more than just going to pick up your prescription. They're convenient and easy to access for the most part, and they offer a really wide range of services now, and you don't always need to book an appointment with the pharmacy. You can sort of call in and ask for a consultation. A lot of pharmacies now have private consultation rooms, which is really nice, and they offer so many more services than they ever have done. So for example, at your local pharmacy, you can get your blood pressure checked for free, which is a great preventative measure. You don't know what health condition might be underlying with blood pressure, so it's really quick and easy to get that checked there. You can access some medications without going to your GP at a pharmacy. That includes oral contraception, which is something that we are working on currently in our team, is sort of advertising that there's oral contraception available for free at your local pharmacy. There's also the Pharmacy First service. Now, the Pharmacy First service has been ongoing for over a year now, and all pharmacies offer this, and they can treat and prescribe medication for 7 minor conditions. And I've just listed some of the ones that might be relevant for winter, which include sore throat, sinusitis, and shingles. So if you have any of those conditions, you'll be able to go to your pharmacy instead of going to your GP. And lastly, just some pharmacy reminders. So Remember to order your medications on time this winter, especially around bank holidays, just so you can get that stock in plenty of time, especially around bank holidays, Christmas, all the rest of it. The NHS app is now live and it's really accessible for a lot of people to use. You can do things like ordering repeat prescriptions on there and managing other healthcare needs. You can also link in with your local practice through the NHS app and book appointments as well. Pharmacies, they have out of hours access as well. So many pharmacies open in evenings and at weekends. And on the NHS website, you can find where your local pharmacy is, and that should help you navigate what services your local pharmacy offers as well. I think that might be it. But yeah, there we go. Questions. Thank you.
Is that the end of the presentation, people?
It is, yes.
Excellent. I absolutely love that. And there's so much information on there. It will be a shame to waste it. So if anybody else on the call can pass on these slides to other people, and we're happy to take questions from any members of the public at any time in order to get all this information out. So everybody needs to get on board and help us with that. So we're going to go into the Q&A. So as we have a hand up from Anne. Anne, do you want to ask your question first?
Thank you. Yes, a very interesting presentation. Thank you very much. The thing that rather concerns me about quite a lot of things is first communication and then, frankly, age. Pretty well, a lot of the things that the elderly suffer from, they can no longer get vaccinations if they're over 80. I'm 94. I would quite like to have some of the vaccinations, particularly for shingles and RSV. But I can't get them without going to Boots. Okay, I'll have to pay what I think is about £300 to get shingles vaccination. My parents both had it in their 90s and were absolutely knocked back. So I really would like that. I happen to have serious chest problems, but I can't get RSV. So a query as to why everything stops at 80. We don't stop at 80. We keep going, and we want to keep going. So that's point one. Point two is communication. I have tried on occasion to get vaccines. It took me 2 hours to find where the spring vaccination was available. I rang my local pharmacy. I rang the doctor's clinic. Neither of them knew where the nearest vaccinations were being held. The ones that I had a list from, the national list, which came on my computer, were all except one over 15 miles away. Now, I happen to be lucky. I have a car. I could have driven there and back, but the nearest was 7 miles away. And if I hadn't had a car, I couldn't have got to any of those appointments without using a taxi. They were the one that was nearest, which was 7 miles away in each direction, was right in the middle of the countryside. There is a local bus that takes you there, but if, like me, you can't manage in a bus, how did you get there? And the other ones were all of one particular group of pharmacies. Boots didn't know that this group of pharmacies were doing them, which is where one automatically goes to find out. But they didn't know. The doctors didn't know. Nobody seemed to know where the local vaccination point within a 10-mile radius of our little city was. So just a few ideas. I think it might be helpful if you're not going to use the Boots pharmacy circuit, that at least Boots might be told where it's going to be. That's when a lot of people go and ask for this sort of information. So just a thought, a little better communication would get, I think, a much better response.
Would anybody like to give a comment about that?
And so which bit should we do first? Should we talk about the finding out where to go for your vaccines? Because I do know that is an issue, and I think some of the complexity arises from the fact that individual pharmacies and GP practices and PCNs, which are the clusters of GP practices, obviously have the option or not to deliver a vaccine. So as a sort of central point, we don't always know easily which are and aren't delivering. And I appreciate that can make it really difficult for patients, especially, to find out where to go. I think most people would probably use their GP surgery as a first port of call, but there are ways of finding out where your nearest place are. I don't know if Carrie, would you like to come in on that?
I
Yes.
think there's one small point, that all the pharmacies in my area were without telephones. You could not ring any of them. So that was a serious problem of finding out whether, for instance, there was car parking near to them. Most of them you hadn't a clue. So even if you were lucky enough to have a car to get you there, you didn't know how far you were going to have to walk to arrive there. They were all in urban areas, apart from the one, in sections of the local towns, Chesterfield and Sheffield and co, were areas that the general public who don't know those particular towns had no idea where they were.
Yeah,
Sorry, I just felt it was necessary to
No, I
bring
wonder
that
if
up at the same time. Thank you.
Thank you. Yeah, because it's quite interesting that, because I phone my pharmacy all the time, because otherwise I'd be constantly dropping in to see if my prescription was ready when it wasn't. So that is interesting to hear that you weren't able to phone pharmacies. Obviously, we can't tell pharmacies what to do, but I think, yeah, accepting and understanding that people have different ways in which they prefer to communicate, and not everyone wants to use the NHS app or go online, I think is really a really important point. So thank you. Thanks for raising it. Sorry, Kerry, I think I cut you off just then.
No, not at all. I was just going to say, I know these things are not always set up perfectly, and I know Laura said it's not something that is within our immediate control. However, the pharmacies that do opt in and the practices that do opt in should all be listed on the NHS website. It's their responsibility also to ensure that any accessibility criteria is also listed. But we can certainly take that feedback on board and make sure that we, through our communications, we communicate with local practices all across Derby and Derbyshire. We can ensure that they are prompted to make sure that those details are up to date on the website as regular as possible. And like I said, I know it's not a perfect solution.
Pardon me, but you see, you're dealing with the quite a lot of elderly people who want this. We are not on the website. You have got to think that there are a good number of people who don't use apps, who don't use websites. You're lucky, in fact, if they have got a phone at all these days. So please remember that from 80 onwards, there are a great many people who are not digitally active.
Yes, of course, yeah. And like I said, it's not a perfect solution. It's just the solution that we have available to us. But like I said, we absolutely can take that on board and make sure that we are connecting with our local practices and making sure that the information is accessible. And that's kind of what we're here to do and here to help with. So if that is obviously an issue and we need to make sure there's some resources that are accessible for people that aren't online, we can work with our local practices to see how we can sort of make some positive changes.
Thank you.
Okay, the first part of Anne's question was to do with why do a lot of vaccinations stop at 80 when a lot of people don't?
Yes. Yeah, and it's a really good question. And it's a question that a lot of people have asked and expressed concern about, particularly since the announcement of the RSV vaccination, which obviously stops at 80. There's no perfect answer to this question. And I suspect that as we get more and more people who are over 80 out and about, that this will the answer to this will change. So the JCVI, who are the committee who are responsible for making decisions on what vaccines we give and when and how often and to whom, have to kind of make the decision based on a number of factors, some of which are related to what the evidence tells us is most effective. Some of it relates to kind of risk benefit, and some of it, is logistics, it's cost, and it's kind of what we have available to us in terms of resource. So they tend to choose the people for their vaccination programs who they know are not only potentially most at risk in terms of numbers of people within the population, but also for whom the vaccine is likely to work the best. So as you get older, vaccines tend to work slightly less well just because of the changes in the immune system, which is why we give different few vaccinations to people who are over 65 to those who are under. And unfortunately, most of the evidence that exists about RSV and vaccines and what works and for whom doesn't adequately really cover that older age group to the point where we could definitively say that it's worth it for patients and for the NHS to have everyone having it. Flu, we have a much greater evidence base, which is why and COVID similarly, which is why we add those. I suspect this decision may well be reviewed, and we may see that change as the vaccination program matures. As we've kind of seen with COVID vaccination, that's changed a little bit. So pregnant women weren't included, for example, to begin with, because they weren't sure on the evidence of benefit and risk, and then soon it became clear that actually was relevant. So the answer is it's a kind of a trade-off between what we know to be safe and what we know to be efficient, and also what's the best use of that finite NHS resource in terms of, if we have this, we have to do this prevention, this is where we put it. But I think it's also absolutely true that people who are over 80 are quite possibly going to want this vaccine, and as I say, I suspect we will see revisiting of the program as they do on a regular basis, actually. Yeah, there was an interesting article I read, I think was it in Saga magazine, maybe someone sent me a link to it about this issue. So you raise something which is definitely not just you who's brought this up. This is something that's thinking about it, and I all I can do from my point of view is say that the JCVI do regularly revisit these decisions and the criteria that they apply, and if they find evidence that they should be doing differently, then they will do so. Absolutely.
Laura, thanks for that. Tony, I see your hand up. I'll get to you, but we do have 2 questions in the chat which we need to get to. So the first question is from Rachel. How do Derby and Derbyshire compare to other areas for vaccine take-up?
It's a great question. And the answer is it varies slightly according to what vaccine we're talking about. But generally speaking, nationally, not just in Derby and Derbyshire, vaccine uptakes, particularly with childhood vaccinations, have been on a downwards trajectory probably for the last 10 years, or maybe slightly even more. And that is something that we have seen mirrored in Derby and Derbyshire. It depends a little bit on who you're using as our comparator, but we tend to be, if you're looking at kind of the Midlands regions, slightly above average in our uptake. If you're looking more widely, we tend to be about average for most things. The difficulty is, as I'm sure you've clocked, because you've separated Derby and Derbyshire in your question, is that when you use a big geography like Derby and Derbyshire, the sheer number kind of masks quite a lot of variation. And actually what we do know is, although Derbyshire as a region pretty much average, within that there are some areas that have much higher than average uptake and do really well, and some areas where the take up is much lower. And that relates into the work that Carrie was talking about earlier, which is that actually there's only so much we can really glean from looking at data at county or ICB level. And what we know is that, you know, the reasons and the behaviours that govern how and when and why people are able to take up vaccinations are really different from different places and different groups, and that's why we've been focusing on doing our best to try and work at that local level and make sure that that gets picked up, because yeah, generally speaking we don't do too badly, but if you break it down there's definitely areas that we need to focus on. And I've just seen Mandy's hand go up, so Mandy, did you want to add to that?
Yeah, just being like quite specific for the winter campaign, because it's only just started. It started September, so just last month. So we've only just, the data's only just started to flow through for flu, RSV and COVID. And what NHS England provides us is just where we compare against other integrated care boards, so usually against the Midlands. So there are like 11 ICBs in the Midlands, and then where we compare against England. So certainly for flu, it is very, very early days, remember, in the campaign. So we are above, for this year, we're above the Midlands and England average. But we're slightly behind this time last year on some of our cohorts that we've talked about. So the under 65 at risks are 2 to 3 year olds and some of our school age campaigns, but it's only just started. We need to bear that in mind. RSV, which is new, so that programme only started in September last year, as Laura said. We do better than Midland and England average, so we're not doing too bad. And then COVID, which has only been running for 2 weeks. We need to do a little bit more work on our care homes, care home uptake. So we are behind the Midland and England average, not massively behind, a little bit, but we are above on the 75 plus and the immunosuppressed, and we're definitely doing a little bit better than last year. So still lots of work to do, and hopefully all the interventions that we've talked about will help that. Thanks.
Thank you very much for that. And the other question from the chat, which Carrie sort of answered, but if she can vocalise it, is from Helen, who asked, what are the 3 lowest uptake areas which will be receiving the bespoke resources?
Yeah, so that I mentioned it throughout my presentation, but I completely forgot to mention Derby City, so huge apologies. So Derby City, Bolsover, North Chesterfield and Glossop are the 3 areas that we've identified have low uptake. They've got bespoke resources, and I'm working with a lot of community leaders in those areas to make sure that this campaign is delivered on a more personal level rather than a kind of forceful get your vaccine level. It's kind of integrating into local community events, that sort of thing as well. So those are the areas.
Okay, and finally, hopefully we've got to Tony. Tony, would you like to unmute and ask your question?
I don't know what you mean by finally. What are you going to do to me? I represent a group in San Diego, which is right on the in Erewash, south of Erewash, right on the border with Nottinghamshire. And so we have all kinds of interesting issues here. We have of attendance to our community hub, which is 4 mornings a week, and we vary between 30 and up to 60 people sometimes who attend. Anne was very eloquent. I'm very impressed with Anne and the things that she said. We've got particular issues in San Diego, like we haven't got a pharmacy. We've got people who suffer with long COVID, which wasn't mentioned, and the implications of inoculations with long COVID. And we have many people who are digitally excluded. And so we try to signpost. We're running a digital inclusion program where we loan equipment, but people are still very reluctant to go on it. And we've just started a health course that we built up, which is how to use the NHS app. We go into that in some detail, and various other things that we're going to build into this. Now, I look old enough, but many of the people are much older than me, including older couples. I'd never heard of RSV before today. So if I'm informing these other people, they certainly haven't heard of it. And so I'm really interested in talking, certainly, Carrie, about what we can do, because I can tell you, if I don't know, because I'm looking at health things all the time, and very much our forte is the NHS isn't as accessible as it used to be, so you need to be looking after yourself. So we do talk about exercising, we bring in specialists to talk about, we bring in chiropractics and other people who can talk about health issues. We get Michelle coming in from Derbyshire, who does blood pressure tests and all other kinds of things. And I think one of you, I think it was Laura at the beginning, talked about community groups who are delivering this kind of extra support. I used to attend these meetings when COVID was in, but I somehow got lost in the process because of the busyness of the things that we're doing. But I can tell you that having people right on the border of Nottinghamshire, we've got people from Nottinghamshire who go to Derbyshire GPs, people from Derbyshire who go to Nottingham GPs, and the NHS app doesn't always link up when people are trying to get information across. So we're trying to sort that information up. But we're actually talking about inoculations here. And so it would be really good for me to be in a position to be able to explain to other people the things which I've learned here today. So I will seek to follow up with, because you send the things through, and try and share that with as many people as we possibly can. So I just wanted to highlight, I'd like to have further conversations as to how I can support the people in San Diego with much of the information that you've been giving out today.
Thank you, Tony. If it's helpful as well, I'm happy to share our communication bespoke packages with you for sharing within your group. In that suite of resources, we've created like a newsletter, which is just general advice and what each vaccine does. We've also created a suite of guides, so you are well informed and you understand what each vaccine is, how you need to book it, when it happens, where it happens, what's in the vaccine, and a whole range of helpful information. So I'm more than happy to share all of those resources with you, and you can take those to your group by all means.
Yeah, is it? And again, Laura was talking about these things that you're putting it into people, something which builds up the defense mechanisms, and you get the herd immunity, which is building up. I remember asking a long time ago when this first started about how do we know that it's safe to take the flu vaccine and the COVID vaccine at the same time. And now many people are saying, well, they're getting it one in each arm, both at the same time. So presumably there is more evidence these days about the safety margins when people are taking multiple vaccines.
Yeah, absolutely. So the way that vaccines work is because they're not, as I say, they're not like drugs or medicines. You're not kind of adding lots of different chemicals. As long as vaccines are not live vaccines, so they don't contain like a live version of a bug, you can combine any number of them and it doesn't impact their safety or the way that they work, which, like when we give babies those combo vaccines. So perfectly fine and safe to have flu and COVID vaccination together. And actually lots of people prefer it that way because it's like, one visit and done, one lot of side effects and done.
Very good. So Mr. Trump can have them and he won't get autism.
He definitely won't. I mean, yeah, I'm sure he has lots of opinions, but no, vaccines definitely do not cause autism.
Thank you very much.
Okay, there's just something in the chat from Helen, which isn't a question, but I think it just needs to be mentioned. She said that I trust the ICB is using the Health Watch research stroke reports about flu vaccinations in under 5. They're on the Insight Library of Reports and via their website. So that's with Health Watch Derbyshire. So there's a couple of reports she mentions. I'll just mention that the ICB, we have an Insight library where we take in all sorts of reports, both local and national, which are uploaded for us. And everybody within the ICB, when they undertake any kind of work, we, of course, try to go data-driven, but also with insight to make any decisions as informed as possible. So does anybody else, probably Laura, have any comment about
that? No, just to thank Helen for pointing that out. And yes, as Lewis has said in the chat there, linked in with this work. I think insight and intelligence are really key, because obviously we have a lot of data in the NHS often, but what we sometimes lack is insight and what we can draw from that. So yeah, it's just such a great resource to have. Thank you. I think there's some hands. I can't see who's
Lewis, you have a hand up.
Lewis
to
is
say
number
something?
Yeah, it was just me. Just to say that to Helen, yeah, we're linking with her, and we are doing quite a lot of work to understand how to kind of communicate the message to them members of staff. So any insights from the report would be really welcome. So we're linking and just trying, if there's any further communication we can put out, any more support we can do, and we're more than happy to act upon it. So yeah, we'll be in touch.
Mandy, you have a hand up?
Oh, you're on mute, Mandy.
And you're mute. Could be a legacy hand.
No, I was on mute. Thank you. Thanks, Mark. One of us had got to do it, hadn't they? It's me. Just on the back of what Lewis was saying as well, and we have done this before. So we work obviously with all our system partners. One of those partners is our LPC, Local Pharmaceutical Committee, that works with all the community pharmacies. And we have put communication out to them before, just to remind them of the eligibility and the the social care workers that are eligible for vaccination. So we can do that as well. I mean, what you've said, Helen, in the chat is not, we are aware of this, aren't we, Carrie? Because when we've done our comms around health and social care workers, we have made that clear about who you are, and you are eligible for vaccination. So we can keep pushing that message as well. But we can work with the LPC as well. Thank you.
And I think we're out of hands and we're out of questions. So if anybody else has a question, they have about 5 seconds to raise a hand or get that in. And we've just gone 2 o'clock anyway, so we'll say going, gone for that. So therefore, I'm going to bring things to a wrap. So first of all, wow, what a great presentation, and there was tons to take away from there for everybody, I believe. Thank you to our main presenters, Laura and Carrie, and also Mandy especially, who came on and gave some great stuff for us. Biggest thanks goes to the audience, of course. We lay these sessions on for you. And if there's ever anything that you want to hear about in the future, please just get in touch with me at ddicb.engagement at nhs.net, and I can get back to you and hopefully set something up. This session will be uploaded, or the recording of the session will be uploaded to YouTube, and I'll email everybody later today so they can have a link to that. Look forward to the next session of Derbyshire Dialogue, which is going to be on the 12th of November. And the title is Healthcare and Community, Building a Carer-Friendly Derby and Derbyshire. So it's all about carers, which we haven't done in a goodly while. So that's the end of today's session. Absolutely brilliant. And thanks to everyone. Bye-bye.
Thank you.
Thank you, everyone.
Yes,
Bye.
Bye.